Okay, Dr. Mehta, you can get started.
Hello, everyone, and thank you for joining us on Spine Time, the Weill Cornell Medicine Center for Comprehensive Spine Care's educational series in conjunction with NewYork-Presbyterian Ox Spine. For those that are returning, who have seen prior Spine Time episodes, welcome back. For our new visitors, this is a great informal opportunity to learn about all things spine related. Today, we're talking about something that may sound a little scary, and I brought together my friends to help us walk through what it means to treat a spine tumor. So Spine Time is brought to you by the Center for Comprehensive Spine Care, which is the center on 59th and 2nd, involving all the different disciplines of spine treatment, including pain management, neurology, rehab medicine, and of course, spinal surgery. Spine Time is recorded and will be found available on YouTube. And there's also the chat function where during this presentation, you can enter in a question and we will do our best to answer it in real time. Of course, it's often difficult to get all the questions answered. So certainly we welcome you to join us for an appointment in our spine center. I'd like to take a moment to introduce my colleagues here. First, we have Dr. Susan Pannullo, who's Director of Neurosurgical Radiosurgery, Dr. Louis Chang, who is Assistant Professor of Neurological Surgery, and Dr. Andrew Brandmaier, Assistant Professor of Radiation Oncology. So Susan, Louis, Andrew, thank you for joining us here, and I really look forward to learning about what it is to have a spine tumor.
Thanks, Neil.
So Susan, tell me a little bit about, what happens when someone's told that they have a spine tumor? I mean, that just sounds incredibly scary. And what should someone be thinking about next?
So there's really two kinds of situations for spine tumors. One is that the tumor comes from someplace else outside of the spine, and another situation where the tumor grows from the spine itself. Within those two categories, also a tumor can be in the bones of the spine, and often we'll use the word spine metastasis or spine tumor to in a general way, but really they're very different situations. In this situation that you see on the first slide, the spine tumor is in the spinal bone. And in other situations, which you'll see in a minute, the spine tumor is in the spinal cord itself. And those present very different scenarios. In a spinal metastasis, as you saw on the first slide, the tumor can be confined to the bone, but one of the problems with these kinds of tumors is that they can then extend outside of the bone, where they might cause minor issues like pain, and then can cause more difficult to manage issues, like if they push on the spinal cord. So you see in that arrow, a tumor that you see on the left has now kind of pancaked the spinal column. And if you remember pictures of spinal bones, it looks like a bamboo tree, and it's kind of bone with the disc in between, and then another piece of bone and the disc. And you can tell that there's a bunch of normal bones, and then where the arrow is, the bone has become weakened and collapsed by tumor that spread from another part of the body. In this case, it spread from the lung to the bone, which is a common circumstance, and is pushing on the spinal cord. And when that happens, that's where my colleagues, Dr. Chang and Dr. Brandmaier, and then myself often have to intervene to manage this kind of problem. If you go to the next slide, you can see the type of condition that I alluded to a minute ago, which is where there's a tumor that went from someplace else in the body, in this case from a kidney cancer, into the spinal cord itself. And that presents its own types of problems and challenges. Obviously, it's a little bit more difficult to get at this type of tumor surgically, but we'll be addressing that kind of challenge a little bit later in the talk with my colleagues. And then lastly, you can see what's called the primary tumor, and that's a tumor that arises in the spinal cord itself and did not come from someplace else. Often, as you may have questioned yourself, it might be hard to tell whether a tumor came from someplace else or whether it started right in the spinal cord. And in those types of situations where you don't know, surgery is very important to be able to at least get a piece of the tumor from the bone, from the spinal cord, from wherever, in order to know what the tumor is. In some cases, if the patient clearly has cancer in other parts of the body, it makes things a little bit easier. And in those kinds of presentations, the patient may not have to have surgery simply for resolving where the tumor came from, because it may be clear from the setting in which it's occurring.
Susan, I mean, that's incredibly impactful information, and thank you for walking us through that. If we take a step backwards for a moment, what are the typical things that people would first experience before there's a suspicion of a tumor? What would make someone go on to get imaging and to find these kind of things?
That's a great question. So in the world of neuro-oncology, a patient who has cancer and back pain, by definition, has to be assumed to have a metastasis in their spinal bones. Without imaging, nobody would know that. So right away, when somebody that has cancer develops back pain, we get a scan, usually an MRI scan, to figure out what's going on. But of course, there are lots of other things that have been talked about in other spine time presentations that can cause back pain in a cancer patient. But we always make sure that we've checked for the tumor traveling to the bone, because that's an extremely common scenario, an extremely treatable scenario, and requires a multidisciplinary team to then come together, like in the spine center, to develop a plan to approach that tumor.
And maybe, this is a good opportunity to ask Louis. I mean, you obviously are involved in some of the cases that come in through the emergency room that are found to have a tumor there. What kind of symptoms would bring someone to an emergency room where they have these kind of concerns?
Yeah, that's a great question. So the symptoms can vary depending on where the tumor is located. And when we go through my slides, I'll show you some of the locations where the tumors
do that.
Oh, is that a segue? Okay.
Yeah, it's, while you're doing that, why not take the moment?
Yeah. So yeah, if you
Tell me what slide is
go to the next one. Go to the next one. So there are a couple ways of thinking about spine tumors. So one is like Dr. Pannullo mentioned, the origin of it. It could come from the spine itself, or it could come from somewhere else and travel to the spine. And the location is also another way to characterize spine tumors. So in this illustration here, if you take a cross section of the thoracic spine, and we're looking up at the thoracic spine here, the chest is towards the top of the screen, the back is towards the bottom, and you have the vertebrae right over here. Oh, someone else's cursor.
Yeah, that's me.
That's the bone. Thank you. So for example, this is a tumor that has traveled to or started in the bone, in the vertebrae, and some of these patients may present with just back pain. It could be pain related to mechanical instability, where because of the nature of the tumor, it could erode some of the bone and make it weak, and they could have pain associated with that, particularly if they're standing up or putting pressure on it. Sometimes patients could get pain known as biologic pain, where it's worse in the morning, and that's due to the tumor itself. So it all depends. But if the tumor is located in the canal where there are neural elements, and this is a cross-section of the spinal cord. And for example, what Dr. Pannullo showed, well, her tumor, the tumor that she showed in the spinal cord looked a lot bigger, but if you had a smaller one in this region of the spinal cord, let's say on just one side, the patient may present with weakness or numbness on that side of the body, and perhaps they could have decreased pain and temperature sensation on the opposite side from the fibers of that go up and down the spinal cord. Or if they have a tumor outside of the spinal cord, but if it's big enough that compresses the spinal cord, then they could also get symptoms of weakness. It could be weakness in both legs. It could be numbness. Sometimes the numbness could be, if it's in the thoracic level, it could be numbness from the chest, for example, chest down, depending on the level that the tumor is associated, or from the belly button down, abdominal region down. They could also present with difficulty with holding in urine, difficulty with controlling bowel movement, or if the tumor is outside of the central canal, but in the region where the little nerves come out, the individual nerves come out, they could have symptoms associated with nerve pain. So it could be a very specific distribution of whatever that nerve goes to. So if it's in the thoracic spine, it may just be some discomfort along the rib cage, along that one level of that nerve that it's affiliated with. But if it's lower down in the lumbar spine, it could be associated with maybe even weakness or numbness in that wherever that nerve travels to. So so that's a long answer to your question, but
Sure, but it's certainly important.
Yeah, it just all depends on where it's located.
So for the group, let's say we now have a patient that has the imaging, we've confirmed a tumor. What happens next?
Yeah, I mean, if you want, I could continue with my slides. So
Sure.
if you go,
I know I skipped over a couple of them, so tell me if you want.
no,
me
it's
to.
perfect. Actually, can you maybe go back a couple of slides? Yeah, why don't we? I think that maybe let's, if you let me, I think I should probably just start with whenever I get called for a consultation in the ER, let's say, and I'm not always the first person to encounter a patient with spine tumor. Sometimes they could be referred to me by the radiation oncologist or the medical oncologist if they've been following a patient for a while with a known cancer and that they start having symptoms that are concerning for maybe metastasis to the spine, and they get imaging, they find a spinal tumor, then I'll get pulled in. But let's say I see a patient in the ER, they call me, it wouldn't be too long before they call the oncology team as well. It's a team approach for this problem. But we always start with a very comprehensive history and physical, finding out the patients when they start having these symptoms, weight loss, things like that. We would do further workup, maybe getting CT of the entire body, and then we decide what's the next best step. But in terms of my role as a surgeon, as a spine surgeon, the things that I would be involved in, or the goal of surgery, would be alleviation of neurologic symptoms or deficits if it's from compression of the neural elements, like I showed before. The other possible role that I have is stabilizing the spine if the tumor is weakening the spine to the extent that it's causing a lot of pain, or there's progression of some deformity, malalignment, or it's unstable. The other goal may be to remove as much of the tumor around the spinal cord and nerves as possible, so that allows the radiation oncologist to then hit the tumor with higher doses of radiation, focused radiation to that region without injuring the nerves or the spinal cord. And in a lot of cases, the role of the surgeon, spine surgeon, is to hopefully extend the quality of life of the patient, allow them to be mobile. And sometimes the role of the surgeon could be to cure the actual spine tumor, depending on what it is, especially if it's a primary tumor, which is a tumor that arises from the spine itself. So those are the rare circumstances where we could actually cure it instead of just removing the bulking, some of the tumor for the radiation oncologist and medical oncologist to then treat. And the final thing that spine surgery can be useful for is to establish a diagnosis. And we generally do this as a getting rid of two birds with one stone thing. If there's an indication for surgery, let's say stabilizing the spine or decompressing the spinal cord, then while I'm in there, I'm going to be removing some of the pathologic tissue and sending it to the pathologist for diagnosis. But to answer your question before, if you go to the next slide, when we get an MRI image, let's say this is the MRI that we come up with and the patient is neurologically intact, just with some back pain, we have some time to figure out what this is. And the importance of figuring out what this is that it has a bearing on exactly how we're going to approach the treatment of this tumor. So the next step in this case, this patient, let's say there's no indication for surgery to stabilize the spine. We don't need to decompress the spinal cord. We could do a biopsy, and this is where we'll pull in another member of the team, which is the interventional radiologist, and they could do a stereotactic biopsy with a little needle, biopsy needle, remove a little bit of that tissue, send it off to another member of the team, the pathologist, and they will determine what this tumor is. So if you look at the different diagnoses that we have, let's say these 4 different diagnoses, depending on what shows up, the treatment is very different. So with the first diagnosis, let's say it's a lymphoma, a lot of times that could be treated just with chemotherapy. If it's metastatic breast cancer, then a lot of times they could do conventional radiation, and then plus or minus systemic treatment. If it's something that's not as radiosensitive, like cancer that arises from the kidney, renal cell carcinoma, then I may be called upon to do that debulking of the tumor, remove as much tumor as I can to create space for the radiation oncologist to do that stereotactic radiosurgery. And the final one, if it's diagnosis 4, that's a primary tumor, chordoma, rises from the spine itself, then the best treatment is to try to do an en bloc resection. It's a much bigger surgery, but there is a chance that if you remove the entire thing, you could potentially cure the patient. So I'll stop there for now.
Thank you for walking through us, what is obviously a very complex situation. I know that this is probably a difficult topic for a lot of our audience, and we welcome any questions that you may have as we try to walk through this. Andrew, walk us through what you discuss with a patient. And I know you were kind enough to put together some slides too.
Sure. You want to, I think, as has been established with Dr. Pannullo and Dr. Chang, you want to establish kind of the groundwork for what you're dealing with. There's a variety of clinical presentations that you can see. And so, as has been mentioned, you want to know the diagnosis. You want to discuss then what the patient's symptoms are to to know what the problem is at hand. You also want to know the extent of the staging if this is a malignant tumor. If you have extensive metastases versus like a focal lesion, your goals or what you can achieve may change. And so once you have all of those things to establish your setting, and then as well, structurally, is the spine compromised? Is there a pathologic fracture? Is there cord compression? Things like that, that will help you then decide what the next step is, because this is an interdisciplinary strategy. The neurosurgery team will discuss a lot of these things with the radiation team and with the neuroradiologist looking at the images, and the pathologist with the diagnosis. So it's all those things have to integrate together to decide kind of the proper order of steps to take. And if it so happens, that then, the next step would be radiation, then then we would have that conversation about what our goals are.
Sure. So walk us through, what does it mean for radiation? What does that entail?
Sure. Let's go to the next slide just so I can provide kind of a context for radiation and why, it nicely, I think, complements surgery for what we're trying to do. So radiation is teletherapy, whereas with surgery, you're able to achieve, in situ objectives like resect a tumor off the spinal cord, or provide fixation for, fracture. Radiation is able to kind of beam in our treatment from what's essentially an X-ray source into the area of concern. So it's sterile, there's no anesthesia. And in particular, that point, I think, matters for maybe patients who are more frail or not in a condition to have surgery, or maybe the field of area that's affected and that needs to be treated is very large outside the scope of a surgery. And those are all things where radiation, I think, can provide use for the patient. The way it works mechanistically, just very basically, is radiation causes DNA damage that kills tumor cells. Normal tissue is able to repair itself. Malignant tissue or tumor tissue is somewhat incompetent at that. So that's how you get a separation. And so you prescribe a dose of radiation to a target of concern to try to maximize the efficacy and minimize any side effects or toxicity. And so units of radiation are called gray. So for a patient, or if you're talking with another physician, you're talking about how many gray. That's just a dose that you're prescribing. And the other part of the radiation prescription is how many treatments will be given, which are called fractions. So there's different prescription strategies, short course, longer course, for different reasons. So that's just kind of an overview of what we would be prescribing for the patient.
Got it. Well, we have a question in the audience. Thank you for sharing this. It says, I have a schwannoma on the intercostal nerve at T8. What does that entail? And have you ever treated this, maybe even surgically? I opened that to the group.
Sure. Well, that starts with an interdisciplinary discussion, because certainly our group, we've treated schwannomas both with surgery, radiation, and then if needed, a combination of the two. So, I could let Dr. Chang perhaps comment on the surgical considerations.
Yeah, definitely. I think a lot of times I've seen patients with schwannomas, and a lot of times they're just found incidentally on MRI, meaning that they're not really causing any symptoms. And in those instances, I tend to just watch them either with serial imaging or tracking their symptoms if they start developing symptoms. So I don't know if you're having any symptoms related to that, but certainly if it's asymptomatic, that's something that could be followed. But if it becomes an issue, if it's causing you problems, then surgical resection of it is possible.
And just from a neuro-oncology standpoint, once the tumor is removed, it will be confirmed, because as we talked about early on, it's important to know exactly what we're dealing with. And probably these days with scans, they're so good that you often can tell pretty much what something is from a scan, but it's important to confirm that diagnosis when it's not 100% clear. So one nice thing about getting it out, especially if there's symptoms or especially if it's enlarging, is to send that piece of tissue to the pathologist who can confirm that it's a schwannoma. And once that's done, which likely it is a schwannoma, then if there's a piece left over, and even if there's not, then we'll do exactly what Dr. Chang talked about, which is to get what we call serial scans, which just means one scan after another, usually every 6 months or a year, sometimes more or less frequently, depending on the situation. And then, for example, if a piece of the tumor starts to grow back, or there's a piece left over that we're observing, and that starts to grow, that's when Dr. Brandmaier might get called in, and sometimes along with me in my specialty in radiosurgery, to do focused radiation to that little spot that's growing, to stop it in its tracks so that it does not continue to enlarge.
A few examples from the radiation side. We've treated cases where patients just aren't surgical candidates. You know, for example, patient with a clotting disorder that can't go off a blood thinner, can't have surgery. We've treated definitively, you know, giving what should be a curative dose to their tumor. And as Dr. Pannullo just mentioned, some scenarios, maybe where there's a little bit of residual disease that can't be resected, or if a patient has had a resection and it has recurred, sometimes radiation is a good option at that point. So there's different scenarios we encounter where radiation's been very useful.
Yeah, the other thing I would add to it too is, like I said before, location matters. So if some schwannomas are pretty far out of the foramen, and if they grow outside of the spinal canal. But there are some that may start growing into the spinal canal where the spinal cord resides, and that could potentially be an issue, and that may be an indication that surgery sooner than later would be better, especially if there's evidence of spinal cord compression or displacement, or even edema in the spinal cord. So that's another consideration.
Wow. I'll have to admit, I'm learning just as much as the patients on this call. What else would you want them to know about your field?
So I think, you started the conversation with saying that this is scary, and it often is. The neural stuff, tends to be scary. People think when there's something going on in their spine, of course, they're worried about paralysis, and when people hear about something in their brain, they find it particularly frightening. But really, nowadays, brain and spine problems are not the same as they were years ago. And a lot of the things that people are afraid of is because even 10 or 20 years ago, we were very limited in what we could accomplish surgically, and in terms of radiation, and in terms of the medications that can be used to keep tumors under control. And now it's a whole new world. And so people should not be afraid. If they develop a spine tumor, it's something that's very, very manageable. If it starts in the spine, or if it came to the spine from someplace else, it's important to tell your doctor about your symptoms so that they can get the appropriate type of imaging, the appropriate type of scan. As you've heard over and over again, the scans are really our window into knowing, what to do, and then to let your doctors work as a multidisciplinary, multi-doctor, multi-specialty team to help to find the best tailored approach for your own type of tumor.
Okay.
And just to springboard off of what Dr. Pannullo just said, if you want to go to my slide where I have the three surgery, yeah, there you go. So technology has advanced also in spine surgery to the extent that we're doing things through smaller incisions, which means less blood loss. There's less risk of infection. but also we don't have to a lot of times make big incisions, and that's very useful especially if a patient needs to undergo radiation treatment as soon as possible after surgery. So the healing time's a lot faster, and we're able to have them undergo radiation a lot sooner. So here, this one example here on the left side, that's basically just cement, the same thing that we use for garden variety osteoporotic compression fracture. Dr. Mehta might use them. I don't know if you do kyphoplasties, but certainly pain management physicians do. But in the world of spine surgery, sometimes stabilization can just be done with cement augmentation by itself. And the nice thing is that I could generally get a biopsy at the same time. So these are not, I wouldn't say majority of the time, but the few times that the patient is amenable for that, it's great because we don't have to put in any hardware. Now, in the middle picture, there are screws and rods to stabilize the spine, and that stuff, the brown stuff in the middle, that's the tumor that's invaded the vertebral body, and some of the other elements that's weakened that level to the extent that it needs the stabilization. But the way that we put in the screws and rods now, we could do it through tiny stab incisions through the skin. So if you look at that picture on the right, the traditional surgery for B is making an incision in the middle of the spine, in the middle of the back, dissecting down, stripping away all that muscle and retracting that aside so you can put the screws in and do the decompression. But now with our technology, we're able to put these percutaneous screws in through the skin, and we use navigation a lot of times in the operating room, which is a GPS system, so that we know exactly where we're putting in the screws, and we know exactly where to make the stab incision on the skin, so that really limits the incision size. And once we put the screws in, we could put the rod through, and if we need to do decompression, debulk the tumor, then I could just make a limited midline incision right over the level where the tumor is, and then do the decompression and tumor debulking.
So we have another question. What would be your treatment for, I assume, just one thoracic level chordoma limited to the vertebra confirmed in biopsy? Would it be en bloc resection followed by proton therapy, separation surgery with stabilization followed by proton therapy, or only proton therapy? So I opened that to the group.
Yeah, I mean, I think chordoma is one of those instances. It's a primary tumor where you could potentially achieve surgical cure of that. But to do an en bloc resection, it's a big surgery. It's that's not a surgery that I think every spine surgeon can do or should do. But proton beam therapy, I think that's been useful for treating chordomas in locations that are not surgically accessible or might be too dangerous to do, like at the clivus, the base of the skull. But I don't know if Dr. Brandmaier has any addition to that comment.
Yeah, I mean, usually we would defer to the initial question of can surgical resection be achieved, and then make radiation decisions based on that.
I think the separation surgery would imply that it's not just confined to the vertebra and that there's a need to separate it. When we talk about separation surgery, you'll hear that term sometimes. And what that refers to is basically making space between the tumor and the spinal cord so that radiation can be most safely done at the highest dose possible. One of the goals of radiation is to limit the dose of radiation that goes to anything except for the target, which in this case is the tumor in the spinal column. And so separation surgery would imply that there's some compression of the tumor into the spinal cord. And in that situation, if that's the case, then at the very least, you would need to do as much surgery as possible. I agree that in an optimal world, en bloc removing, the entire tumor would be great for chordoma, but realistically, sometimes it's difficult, which is why often a combination of surgery and radiation is done. If it's truly limited to the spinal segment that's being described, then proton therapy alone is reasonable. But optimally, it would be surgery and proton beam therapy.
Well, we're wrapping up. If you're a patient and you want to know why Weill Cornell is the place to be for treatment of a spinal tumor, here's your chance to be proud and brag about the team that you have. What separates us from our peers in the New York area or even outside of New York?
I would say hands down, it's our multidisciplinary team approach. We are very collaborative and really take the patients on as a group. And we're always talking about making sure that we have the opinions of the most experienced specialists and that we put our heads together for every case. I do want to address the patient that was asking about being bedridden with pain, and want to make sure that we let you know and other people that are having pain that is a part of our multidisciplinary team, is being compassionate, being holistic. As you saw on the first slide from Neel, one of the parts of the team that's amassed for a patient with a spine tumor is integrative medicine. So helping make sure that your pain is controlled, your quality of life is good. And I think we look at patients as a whole and make sure that we're doing everything, not just to manage the patient's disease, but to help the patient feel better, function better, and live longer.
No, that's very comforting to hear. And it's certainly been the secret to success in our spine center in general, to have that multidisciplinary team. I've put the appointment number there, our website, and also an opportunity to see previous episodes of Spine Time. I want to take a moment to thank my guests, my friends, Susan, Andrew, and Louis. Thank you for teaching me and teaching our patients about this. And we welcome you in 2 weeks again for another episode of Spine Time. This time to talk about osteoporosis and bone health, especially leading into surgery. Another great opportunity there. And so I wish everybody a good night, and thank you again for joining us.
Thank you, Neel, for having us.
Thank you. Night.